Well, I think I'll go ahead and get started in the interest of time. So I'm CatherineHart. I know I've met a lot of you. I'm one of the ENT doctors here. I don't do the ear stuff. I leave that to Dr. Chu, and I focus more on the airway aspects of things. So we're going to spend a little bit of time talking about secretion management in kids who have charge syndrome. This is a really small group, so certainly feel free to ask questions at any point, or if you have comments or anything you want to add, by all means, please do that. So we'll spend a little bit of time just talking about what problems secretions cause. Why do we really care about them? Drooling and aspiration are the two big things, and then we'll spend a little bit of time talking about some of the management options. It's a lot to cover in just 30 minutes, so we may not get through all of it, and there'll probably be a lot of questions that we can hopefully address either at the end or this afternoon when we have the question and answer session. So drooling, or the medical term for it, which is sialuria, is just defined as a loss of saliva from the oral cavity, right? And it can be small amounts, or it can be copious amounts. It's really common in kids under 2, regardless of whether or not they have any underlying diagnoses. There are lots of reasons that babies do it, toddlers do it. And really, we all make a ton of saliva on a daily basis. So in an adult, you make anywhere from 1 to 1.5 liters of saliva every 24 hours. So if you think about that as like a 2-liter bottle of soda, and you're making half of that every day, so that's a lot of liquid that has to go somewhere. The major salivary glands produce the bulk of the saliva, and those are paired glands. You have parotid glands that sit in your cheeks, submandibular glands, which are the glands that live under your jawbones, and then sublingual glands, which are the glands that live under your tongue. And the parotid and the submandibular glands are actually responsible for like 90% of the saliva that you produce on any given day. You also have hundreds of little itty-bitty tiny salivary glands lining the whole inside of your mouth, and those you can't make go away. So the innervation of the salivary glands is entirely outside of voluntary control. So there are two things that kind of influence it, part of the autonomic innervation. The parasympathetic, or the rest and digest system, which causes salivary flow to increase, and it makes the secretions get much thinner and much waterier, or the sympathetic system, which is our flight or fight response. And that actually causes the salivary flow to decrease, and it will cause the secretions to thicken. Why do we need saliva? It actually plays a really important role. It can be a huge hassle if you have too much of it to deal with, but we need it. It helps keep our mouths moist. It helps moisten and cool food, so that helps both in dissolving the food and starting some of the digestive process. It buffers acid, so acid either in food or acid coming up from your stomach, and therefore helps protect your teeth. And it, like I said, there are enzymes in it that actually start the digestion process. It also has some antibacterial properties. So really, saliva is an important thing. You don't want it to go away completely. So we make all this saliva. Why is it that we see, some people drool, some kids drool, and other kids don't? There are lots of things that can contribute to drooling. Some of it is just poor oral motor control, right? So if you don't have good control of your tongue and your lips, if you can't keep a seal up front, you can't keep the saliva in, and it just kind of spills over. We see in some kids that it's because of inefficient swallowing or decreased frequency of swallowing. They can swallow okay, they just don't trigger swallows as regularly. So again, you get pooling of those secretions of the saliva, and it has to go somewhere. If it's not going down, it's going to come out. In some kids, it's just developmental delay. They just don't have the skills to keep the saliva moving back in their throat to get it swallowed. And it can also be because of structural problems with the mouth, where the mouth, isn't closing appropriately, and therefore it's harder to swallow. And then we see it in kids who are either mouth breathers or have some upper airway obstruction. So one of the classic ones of these is kids with really big adenoids. Adenoids live in the back part of the nose, and they can block the nasal airflow. And if you have really big adenoids, you breathe with your mouth open. So if you'll have a child, they keep their mouth open. And if you sit and keep your mouth open for about a minute or so, and then let some of the saliva build up, and then try and swallow with your mouth open, you can't do it. So kids who sit with their mouths open all day, you physically can't swallow if your mouth is wide open. And so again, the secretions kind of spill over. One of the key things is that Drooling is not a problem of overproduction. These kids aren't making too much saliva, they just can't deal with it appropriately. So they're not making any more than anybody else, it's just not going down the esophagus. And why do we care? What's the impact? So a lot of you have experienced this. If you have a lot of drooling going on, it can cause physical discomfort, right? If the secretions are always kind of spilling over onto the chin, you can get infection or eczema around the mouth. Some kids can drool enough that they actually get dehydrated. And then we also, in kids who aren't handling their secretions, can see aspiration and recurrent pneumonia. So it can be a significant impact on their health. Independent of kind of the health issues, it can have a huge impact on hygiene and just quality of life, right? So there's the stigma of having a child who's constantly drooling, especially as kids get older and get school age. If they're constantly having to wipe secretions, it's something that makes them very self-conscious at school and can cause them to sort of be isolated from other kids or have self-esteem issues. So there are lots of potential ways that this is impactful. And when you look at kind of the other side, what's the impact on the caregivers, right? So we know it can create some health problems and some issues for the children themselves, but for caregivers, and this has been studied, there's a really huge burden of care that can come with too much drooling. So in a study that looked on this impact and tried to measure the impact, they found that on average, the caregivers were wiping the child or wiping the face 73 times a day, which is, when you stop and think about how often that is, it's almost like a constant undertaking. And then you start to factor in how often you're having to change clothes because the shirt is soaked, soiling of the environment, so the pillows are soaked, the high chair is soaked, everything is getting wet. In some of these families in this particular study, we're doing up to 25 loads of laundry a week just to keep up with the additional needs from all the drooling. Then there's the impact of being hospitalized, so kids who are getting recurrent pneumonia and ending up in the hospital, and then just the anxiety and worry component that comes along with this, as well as some social isolation for families, if it's depending on how extreme the problem is. So there have been some efforts to try and quantify the impact of drooling. And this, I think, is a nice scale that helps you kind of get in your mind how much of an impact it is that the drooling is having. And so it's looking both at the frequency, so how often is drooling a problem? And you can see, it's either ranges from never to just sort of every once in a while, not every day, part of every day, or constant. And then the severity, right? So the lips are always dry, mild drooling, and then to the more severe or profuse where there's just saliva everywhere. And so, that looks at kind of the sort of the impact and some of the social factors and just the hygiene factors. One of the big things that we really focus on and that really makes us proactively manage sialorrhea or drooling in kids is the aspiration bit of it. So what you're seeing in this video is actually, it's a FEES study, which probably many of you are familiar with. It's where the little camera goes in the nose while the child is being given dyed liquid to drink. And we're watching to see, does the liquid go down into the voice box? And that's the definition of aspiration, is material that you're attempting to swallow passes into the airway. You can aspirate anything, really, so liquids, food, including solid food, saliva, right, which you produce, or you can aspirate reflux that's coming up from the stomach into the back of the throat. And all of those things can create problems. You'll often see an aspiration that kids cough or choke when they're given feeds or given something to drink, but it can also be silent. So you get no cough response, the liquid's going down, and there's no effort to try and cough it back out and clear it. So when we look at aspiration specifically in kids with Charge syndrome, we've found, and this was out of a study a few years back here in Cincinnati, that 60% of kids that had come through our center up to that point demonstrated some signs of aspiration, whether it was seen on a video swallow study or on a FEES exam. But that's a pretty high percentage. And we know also from other studies that about 80% of children with CHARGE syndrome have some degree of swallowing dysfunction. And that can vary from, pretty mild, where it's just certain textures that they're avoiding, to not being able to take anything safely by mouth. So we know it's a really important consideration, and something that we at least consider in all of our kids that come through the center is, are they aspirating, and to what extent? So why is it that we see such a high rate of aspiration in kids who have CHARGE syndrome? We think there are probably a number of factors that contribute. So we know that the larynx, or the voice box of kids who have CHARGE syndrome, anatomically or structurally is a little bit different than what we see in a child without CHARGE syndrome. So if you look at these two pictures, I don't have a pointer, so I'm going to just walk over here. Up on the top is a normal voice box. And one of the key things to notice is that you have a really clear view of the vocal cords, right? Those two white structures that look like an upside down V. When you look at the larynx below that of the child with CHARGE syndrome, everything is much more crowded right through here, and you don't actually see the vocal cords. And this is a pretty characteristic appearance of a voice box of a child who has CHARGE syndrome. Of course, there's some variation, but we think that crowding contributes to some of the swallowing issues. We also know that there's a really high rate of cranial nerve abnormalities, or alteration in how the cranial nerves work in kids with CHARGE syndrome. And there are any number of cranial nerves. There are a total of 12, but almost half of them contribute in some way, whether it be from a muscle movement standpoint or a sensation standpoint, to our ability to swallow. So even the slightest abnormality in one of those nerves can really be impactful on the swallowing sensation. One of the biggest things that we see in a lot of kids is that they actually have decreased sensation at the level of their voice box. So the secretions get down there and they don't cause the child to cough, which is one of our most important protective mechanisms to keep things up out of our airway. When you combine all of this, we often see some decreased swallowing function. So this again is just another view, a couple ways of how we assess for aspiration in kids. So you can see on the one side the video swallow study, which as you watch, you see the dark bolus during the swallow, and you can see material going both down the esophagus and down the airway. I'll try and point it out right here as it happens. And you can see there's a little black streak going down, two streaks going in parallel. You don't want to see that. That means that stuff is going down into the airway when it's also going down into the esophagus. And then this is actually a FEES sort of showing the complementary view. So the FEES lets us look from the inside, whereas you can see the video swallow study is sort of letting us look from the side, and it both give us really important information about how the swallow is working. So what do we do when we have a child who's aspirating? What are our options, right? And the options are going to really depend on the severity of the aspiration. So if a child is maybe getting a little stuff that kind of gets down to the level of the vocal cords but doesn't pass into the airway, but is getting some infections, sometimes we can get away with just thickening the feeds. Thicker material is harder to aspirate, and so oftentimes by just taking something from that consistency of water and making it a little bit thicker, a child can safely can safely control it and manage to get it down the right tube. And sometimes we have to, go to more extreme measures where we're placing a nasogastric tube for feeding, or even surgically placing a gastrostomy tube. And again, a lot of this is going to just depend on the severity of the aspiration, as well as the extent of it. Question?
Because I've gotten different answers, so I'm curious your opinion. If we're G-tube feeding, but doing like thick blended diets as opposed to thin formula, can that change the amount of secretions a child has based on, because the fluid levels are different?
So probably. So the question was the role, and you're feeding through the G-tube with the question was use of sort of standard formula when feeding via G-tube versus using like a blenderized diet where the consistency is a little bit thicker, and what impact that might have on secretions. So certainly, even if you're feeding into the stomach directly through a G-tube, if you're using sort of a standard formula, that material is going to be a little bit easier to reflux. So if a child has pretty significant reflux, I think you can still see more of that making it up to the back of the throat, right? So if the consistency is thicker, it's harder, even if there's if the child is refluxing, it's harder to get that thicker material to pass up against gravity. So I think, yes, you probably do see a lower volume of secretions if the secretions are coming from reflux. I don't think we have enough evidence to be able to say for sure, does that thicker consistency impact, say, the amount of oral secretions produced? I would tend to think probably not, just because of kind of the mechanism by which they're made, but certainly if you're refluxing less, even if it's a small change in the amount of reflux, that's less stimulation, right? So if you're getting stuff up in the back of your throat, it actually can stimulate more secretion production from your salivary glands. And if you're taking that away, you might be getting overall less reflux. But that's sort of theoretical. We don't have any actual evidence to back that up. All right, so what other treatment options, so that's kind of for the aspiration bit of it, right? And if your child is aspirating, we're going to treat that really aggressively, because anything that gets down into the lungs, if that aspiration is ongoing, if it's chronic, if it's not treated, that damages the lungs, and after enough time, that lung damage becomes permanent and we can't reverse it. And if it goes on for too long, it can actually create really significant problems for the lungs. It causes basically scarring of the lungs, makes them not work effectively, and can result in need for oxygen and more invasive treatment from a pulmonary standpoint. And so that's why if you have a child who's aspirating, we're going to be pretty aggressive up front about trying to manage that part of it. In a child who's not aspirating but really just has a lot of secretions, or is doing both, there are a whole variety of treatment options that we'll spend a little bit of time talking about. One of them is doing nothing, depending on the severity of the symptoms. There is some role for some physical and occupational therapy, some oromotor therapy, and some rehab therapies, and that's effective in some kids. And then there are medical and surgical options, and we'll kind of touch on some of them. One of the big components, and again, this is some of this conversation is more applicable in kids who don't have significant aspiration, because like I said, that we're going to manage really aggressively. But in kids who just have a lot of drooling, really we're going to manage based on kind of family expectations and family desires, right? So a lot of families, in a child who's drooling constantly, needing to be wiped or have bibs, families they want to reduce the volume so that it's easier for the child to be out and about, reduces the overall care needs, try to minimize the number of times you have to be coming in for appointments or for physical therapy, and trying to limit the number of times that the child's ending up in the hospital. So the no treatment option, this is for the kids who don't drool all that often, or where it's not causing that much of a day-to-day impact. And especially in those kids where we anticipate that with a little bit of time it's probably going to get better, or for whom the drooling is just like way down here on the priority list right now. They're bigger fish to fry, and that's going to get dealt with down the road. So we don't have too many kids that we do the absolutely no treatment option. I won't spend a lot of time going into the therapy options, but there's some oromotor therapies. And this, again, a lot of this depends on the age of the child and their developmental abilities, but you can do some things with verbal cueing and some tongue mobility things that help the child sort of remember to swallow. And some of it is just correcting situational factors, right? So things, if you have a child who doesn't have good head control, and if their head kind of falls off to one side, that's when you see the drooling. And sometimes just, repositioning so their head is held in a more favorable position, and then the secretions, gravity can help work with you and pull them down. And then there's also some behavioral therapy, and again, this is more effective in the older children, who can respond to sort of instruction in prompting and positive reinforcement and that sort of thing, as well as some cueing techniques and things like that as they get older. Medications is, I think most anyone who has a child with significant amount of drooling ends up having some experience with at least some of these medications at some point down the road. Most children, about 80% of the time, they'll be effective when they're first started, and depending on the medication, you see that drop off as time goes by. And there are basically 3 big medications that we use and that we'll talk about. So Robenol, scopolamine, and then Botox, or the botulinum toxin. So Robenol, this is actually a really effective medication. It works in about 95% of kids when you first start it. But what ends up happening is over time, you often have to increase the dose in order for it to still be effective. The body sort of becomes resistant to it, and you end up being on, for about 20% of kids, you end up on needing a dose that's high enough that the side effects make you have to stop it. And the side effects that we see, and these we see pretty commonly, are dry mouth and thick secretions. And then for some kids, especially the thick secretions, if they have a trach or have trouble coughing and clearing, that can be a big rate limiter, right? If you thicken things up too much and you can't get them out of the trach, it creates other problems. Some kids can have issues with flushing of their faces. They get real red with this medication, or they can develop urinary retention, and that can often lead to having to discontinue it. Scopolamine, so the patch, we often think of it as a motion sickness patch, but the way it works, it actually helps dry up secretions as well. There's a little bit of a delay in response. It can take about 24 to 72 hours for this one to kick in, and it's really common that this makes people pretty sleepy just because of the way it works. And so that, for a lot of people, is a big limiter. Especially in the slightly older kids, it can make it really hard for them to focus, and it can actually affect your eye's ability to accommodate. So our eyes will kind of change the size of the pupils, and the scopolamine prevents your eye from being able to do that effectively. So it can make reading really difficult. It's like going to the eye doctor and having your eyes dilated, and for that period of time, like you can't, you can see, but only if stuff is really far away, and the scopolamine can have that impact as well. Botox. So Botox is an injected medication. We inject it directly into the parotid glands and the submandibular glands primarily. And it actually works by decreasing saliva production. It blocks the release of a neurotransmitter that directly impacts the amount of saliva that's produced. And that's how it has its effect. It usually lasts anywhere from 3 to 6 months, depending on what study you look at. And so it's something that has to be repeated if it's effective. And so this is just a little cartoon of how it goes about blocking the release of the neurotransmitter. And by that neurotransmitter not getting released, that prevents the stimulation of the saliva production. So the big downside to Botox in most children is that it has to be done under general anesthesia. They don't typically tolerate this away. It's not a super pleasant thing to have done because it involves a couple different, it's a really small needle, but it's a bunch of different pokes. And so almost universally, at least here, we do it under general anesthesia. And it's done with ultrasound guidance. So you can see the ultrasound probe being used here, and that's to make sure that we're actually getting the Botox into the gland that we're looking for. And then the Botox is injected, and we will typically inject both the parotids and the submandibular glands. So when you look at some studies of this, one of the biggest studies looked at 97 children. It was effective in about 62%, which isn't, it's a little better than half, but not fantastic. It was partially effective in 8%, and it had no impact in about a third of the children. The average effect in this study group was 4 months, and that ranged from really short duration, so some kids who benefited but only for less than a month, and some who actually benefited for almost a year and a half from it. The most common complication is that there can be some intermittent or some short-term dysphagia, so some short-term worsening of the swallow function, depending probably on a combination of things. There's some thought that it might if the injection doesn't make it in exactly the right spot, it can have some impact on the tongue's mobility because it also, Botox, it's sort of more commonly known for being used in cosmetic purposes, and it's injected into the muscles to paralyze them. And so if you injected too much of it, say, into the tongue, it will keep the tongue from moving effectively. But we also think that some of the dysphagia comes from issues with the secretions getting a little bit too thick, which can actually create swallowing issues as well. So medical treatment has a role. A lot of times we'll use it as a supplement, or we'll use it as sort of a trial run, which is oftentimes what we'll do with Botox. We'll see how kids respond to it, and if they have a great response, then we talk about a more long-term option. But what we see is that, especially with the medications, and you also see this with Botox, that they become less effective over time. So it may work really great the first time you inject it. It may work sort of great the second time, but when you get to the third time, you might not see any response. So you start having to increase the doses of the medication, and then you start looking at increased side effects. And a lot of times you eventually get to the point where the side effects are too great, and you can't continue on the medication. So we already talked a little bit about the complications of the medications, and I guess one thing I didn't mention with the botulinum, there have been reports of respiratory failure and death. These have not been in children; they've been in adults who've gotten it for neurologic disorders. They'll get Botox, but that has been reported. So when do we start thinking about surgery? When is this a consideration? We obviously don't jump to this in every child who's drooling because it's a pretty involved approach otherwise. But we start considering it in kids who failed medical therapy. So the Botox didn't work, they can't tolerate the Robenal, or it just has become too much of a hassle. The Botox works great, but to come in every 3 months and undergo a general anesthetic to have it done is, that's a lot of anesthesia and it's a lot of time. Kids who are just drooling profusely and the medications are helping but not helping enough, or in those kids who are aspirating and having significant issues because of the aspiration. So there are a variety of surgical options. Sometimes we just relocate the salivary ducts. So those of the 4 big glands, the 2 parotids and the submandibular glands, they have a little tube that connects the gland into the mouth. And in some cases, it's appropriate to just take the tubes and redirect them so they're more posterior into the mouth. We almost never do this because when we're doing surgery for secretions, it's usually because kids are aspirating, and the last thing we really want to do is route the tube right over the voice box and sort of create a direct path. So that procedure is very, very rarely done. Sometimes we'll just tie off all 4 of those glands, right? So we'll tie off the duct, that little tube that connects the parotid glands and the submandibular glands. The nice thing about that approach, it's all through the mouth. There are no cuts on the outside, but it has some higher rate of failure. And then we sometimes start talking about actually removing some of the glands. And when those things don't work, we will sometimes do what's called a tympanic neurectomy, which is actually through the ear, and it's cutting a nerve that controls some of the salivary flow. And a lot of times we'll do some of this in combination. So if you look at the success rates of some of these procedures, with the salivary duct relocation, we see about 80% long-term control for the drooling part of it. But again, not very good for aspiration. When we ligate the 4 ducts, it's about 30% long-term success, and the tympanic neurectomy is about 75%. So here, the most common procedure we do surgically, if we're going to discuss a surgical procedure, is what we call a drool procedure, because it's a lot easier to say than bilateral parotid duct ligation and bilateral submandibular gland excision. So basically, you're going to take out the two glands underneath the jawbone and tie off the duct from the glands in the cheeks. This is the most common combination, and it's about 87% successful. So that's pretty decent. The biggest complications with this, in some kids you can get some dry mouth, right, because you're taking away like 90% of the saliva production. And one of the nerves that controls the lower part of the lip runs kind of right along where that submandibular gland is. So there's a high risk of temporary injury, and in some cases permanent injury to that nerve. We've already talked a little bit about some of the complications. And when we look at surgical options, yeah?
Did you say earlier that 90% of your secretions come from your submandibular?
But the parotids and the submandibular combined.
No, if you've had both of those procedures done and you still have a lot of secretions, are all the other smaller ones just kicked right up?
So in some cases, yes. They're just they can absolutely ramp up. So the question was, The question was, if you take out if you do the procedure where you tie off the parotid ducts and take out the submandibular glands, do you sometimes see that what we call the minor salivary glands increase their production? And yes, you can see that, that they kind of take over and create more saliva. Yeah.
So my son is kind of my son is 20 months and they have not ever been able to locate one parotid, only a tiny on the other, and neither submandibular, so is it likely that his other ones are causing all of his secretions? Because we suction pretty frequently.
Yes. So the question was, if some of the glands are missing, which they can be congenitally, it's not incredibly common, but it's not unheard of, then the other salivary glands are probably ramping up their production to compensate for that absence.
So something like that, these types of procedures are
Probably not effective, right? So if you don't have the parotid glands, or if they're very, very tiny, they're probably not creating much in the way of saliva, and these procedures would not be terribly impactful. All right, so just quickly, sort of options that we start to consider when we've done those things and they're not working, and these are options that we consider not necessarily as a first resort, but a tracheotomy, right? So there are lots of reasons we might consider a tracheotomy. We will sometimes consider it in the setting of aspiration in order to help keep the lungs clean and help. A trach doesn't prevent aspiration. It doesn't keep anything from going down into the airway. It gives you a mechanism, an easy route by which you can suction the secretions and keep them clear. So it's certainly not preventing it. It's just helping you keep the lungs clean. Question? Not necessarily, because what happens, so the question was, if the trach is cuffed, does that prevent aspiration? It can prevent it intermittently, but the trouble even with a cuffed trach is that usually at some point you're going to let the cuff down, and any of the secretions that are above the cuff they're going to be able to flow past. And more commonly than not, even with the cuff up, there are times or positions that the child gets in where there's still space around the cuff and the secretions can still make their way past. So no, it doesn't. It might minimize some of it, but they'll still have a way past. So the trach, we're more likely to recommend a trach if there's an additional airway issue or if the aspiration is really severe and we're really worried about kind of that ongoing or chronic damage to the lungs. And probably one of the most extreme treatments that we talk about for really severe aspiration is what's called a laryngotracheal separation. This is where you actually take the voice box and surgically separate it from the trachea so that there's no longer a connection in the back of the throat down into the airway, right? So the end, it oftentimes looks like a trach, or we keep a trach in there, but the end of the trachea is actually sewn up to the neck and there's nothing connecting up above. We typically only resort to this if there's really bad damage to the lungs, and usually only in kids who are not functionally able to communicate by talking, because by doing this you take away their voice. So if you have a child who's talking, we don't like to resort to this because you lose that. And we'll stop there. And we probably don't have a lot of time for questions right now. I don't have the agenda right in front of me, but you guys all do. But there's a question and answer session later, and I'll be around if you have individual things that you want to ask. Yeah?
Okay. Why have I never heard of tympanic neurectomy until today?
It's not so question was why has she never heard of tympanic neurectomy? It's not our first line.
You've done everything else. Wouldn't that be something you do before a trach?
It depends on the situation and the child, but it's certainly a consideration. It's done through the ear. It's like an ear surgery. There's a nerve that kind of runs through the middle part of the ear that's part of that salivary control. Sometimes it's only effective, again, in a child who doesn't have, say, parotid glands. It's not going to be helpful. Or if you've had the other procedures done and the parotids are no longer producing saliva, it's also not going to be helpful because it doesn't have an impact on those minor salivary glands. So typically what we'll do if we've tied off the parotids and there's still a lot of secretions, there's a radiologic study you can do that lets you determine if the parotids are still producing saliva. If they are not, then a tympanic neurectomy is not going to help. If they are, then it's a consideration. All right, other questions at all right now?